Status Epilepticus is like a normal seizure. It lasts but much longer. It may last for minutes, hours, days, weeks actually.
Fellow Homo sapiens. Now, who knows much about status epilepticus? Well, it is what we call a seizure that lasts longer than 5 minutes, or when seizures occur very closely together and the person doesn't recover consciousness between them. Status epilepticus is a medical emergency, and the longer for which it continues, the more dangerous it becomes. So it is brilliant to have Christoph Beier from Odense University Hospital in Denmark to share with us his extensive research into status epilepticus.
I'm a professor of neurology and neurologist working at a university hospital in Odense, which is a town in Denmark, the center of Denmark actually. And I'm leader of the head of the epilepsy clinic.
What is that? What type of research are you doing? Because it's such a complex disease. I mean, there are so many things one could do. What's your focus?
I'm a clinician. I'm working with patients, with epilepsy patients, and actually my research is kind of a help yourself research. I've patients that are sick, that need help. And then I look at the books, and I don't find the answer to the challenges the patients are facing. Then I look at the literature, and don't find an answer either. So this is what the starting point of my research, actually, the patients I'm treating.
And your patients, are they adults or children?
Exclusively adults.
Okay. And so I understand that one of your foci, or your main focus, is status epilepticus, which is a pretty dangerous, ongoing, serious seizure, which can be fatal, of course. Can you tell us a bit about that, please, and your papers that you've written on that?
Status epilepticus, as you mentioned, is the worst type of seizure. And actually, only half of the patients that come in our department have an epilepsy diagnosis before they are diagnosed with status epilepticus.
Wow.
A considerable part of those who have epilepsy, they simply forgot to take their pills, and happily, the outcome of these patients is usually good. We manage to stop these patients. And then the other half is kind of a mixture. Like epilepsy, a lot of diseases, we have epilepsy. The symptom maybe genetic, maybe structural, maybe brain cancer, many different things, and the same heterogeneity is seen among those patients with status epilepticus. So there is not one typical status epilepticus patient.
Your reason for researching status epilepticus, can you tell us exactly what that is? Is that for, I imagine, because it can be pretty dangerous?
Status epilepticus is like a normal seizure. It lasts but much longer. It may last for minutes, hours, days, weeks actually. We have rarely as patients which have seizures over a month or longer. And it's dangerous, and a lot of research has been done the last years, actually. So our treatment is getting better and better. So the first steps in treatment is pretty straightforward now. We have to give benzodiazepines. Some of the listeners may know that Bucolam or intrabuccal midazolam. The next step is intravenous anti-seizure medication, typically levetiracetam, Keppra. Some other gives valproate, acid, or phenytoin. And quite a considerable part of the patients really stop seizing after these two steps. But about 1/5 remains, still continue with their seizures despite this very aggressive treatment. And then we are in a stage where we don't really know what to do. And the main problem is, we can stop everyone to seize. This is no problem. We send them to the ICU, we give them sedation, and then the seizure stops. But this is very aggressive treatment, and it's very controversial if this actually helps patients, because you sedated the risk of pneumonia, some needs trachostoma and other complications. And there's some, the other way is just to keep on giving IV anti-seizure medication on the neurological wards. And this is one of the big unsolved questions, how to treat this status.
And I can speak from people that I've known. I've actually been in status once, but it was really unusual. It was focal aware status, which was not a common thing, and that was pretty scary. Other people that I've spoken to have been into status, it scares them to death, or just the thought of it, because it may have happened more than once. Obviously, it doesn't scare them during, unless they're aware. Most of them aren't. And just the worry of well, understandable worry of, death, really, because it is so dangerous, correct?
It's really dangerous. And this is one of the things I'm really working a lot about is prognosticate. How do we find out how will this severe disease end? Is there a chance to survive in a decent condition? Or is it just a hopeless condition? When to stop treatment, how to treat it? Because no one is interested in getting over-treatment, being on the ICU for weeks without any realistic chance to survive this condition. On the other hand, it's one of the nightmares for a physician to say there's no chance to help this patient. And it turns out there was a chance to help. This is horrible for everyone involved in this treatment. So to find a way to prognosticate, to find out what is the chance to get out of this in decent condition is one of the things I was focusing on, and this is what we published last year. It was at the end of 5 years' work, actually, where we had our patients in a department in Odense, and we really tried to look out. We not only did they survive. There's a lot of research in do you have your beating heart at discharge, but do you survive in a decent condition? And we used this as an endpoint. And using this, we found actually 3 things that were crucial for outcome in decent condition. It was age. This was not new. Elderly people are far more severely affected. The other thing is if you are already very sick at the very beginning of the emergency room, coma, arrival, this is bad. But the third thing, and this is very important for practical, it was the duration of the seizure. How long does it take? And I think this was one of an additional support for the concept time is brain also in epilepsy. We know this concept from stroke. We have stroke units, we have stroke halls in every bigger hospital actually around the world this time. But we don't have something for epilepsy. And the worst thing was it's necessary because if you look at how those people which are suffering from having a status epilepticus, how's their survival? It's actually as poor as renal cell cancer. So after 2.5 years, approximately half of the patients we had in our department were dead. So for various reasons, but it's as serious as renal cell cancer if you get diagnosed with it. And I'm not sure if the hospitals currently have the sufficient attention on this condition.
And I haven't heard that statistic quoted by anybody else, actually, by any other clinician. So just to be clear, the average survival time that a person would survive post status epilepticus as a whole is 2.5 years, just like someone might say if someone has a cancer. Is that what you're saying?
That's what I'm saying, which is like all statistics in medicine. If you take all the patients, we took those from 2008 to 2017 from our department, but it was a very nice collaboration with Adam Stretzig from Germany, and we looked at those. They also have a long-term follow-up for those patients, and actually they had an even worse statistics. So doesn't have something to do with our department. We are bad doctors. It's
no, of course.
with condition. And if you look at the statistic work we did, I think it's as we're told, it is heterogeneous. So we also have to look at etiology. It makes a huge difference if you have a known temporal lobe epilepsy and forget your medication, then the risk of surviving is pretty high as compared to brain cancer. So the heterogeneity of the etiologies really contributes to this. Also, when we look at patients that had no acute brain disease, like a structural epilepsy, they were doing alcohol, taking illicit drugs, whatever, all this can trigger status epilepticus. Also in these patients, we see a high mortality, which is predicted by the seizure duration and the age, essentially.
So, for instance, I met this chap once he was an alcoholic. He was in treatment for it in hospital, and he said that he stopped drinking once and he went into status epilepticus. because it wasn't being like, I think he stopped drinking on his own. He wasn't doing it with any help or anything from clinicians. And so he just stopped drinking and he went into status epilepticus. So I think that's it's interesting that status epilepticus doesn't just affect people diagnosed with epilepsy, but there can be many things that cause it, correct?
Yes, definitely.
What has been the response to your papers on status epilepticus? Like, what has been the feedback? Have there been any changes made in hospitals as a result?
I'm not sure. I got some personal analysis, which the feedback was positive for this prognostics score. I'm wondering how many people are actually using it. Those people I'm talking with, they think it's quite a good tool because there are a lot of people working this issue. But most of them, they want to predict if the patient is beating hard at discharge. And all the scores are actually determined. If you come in the hospital, all the other scores, they are, you have your score and you have your prognosis. But this is not the real life situation. The real life situation is that everyone gets a standard treatment, the first 2 steps. And after a day, the consultant is asked how to proceed. So all the elderly patient, young patient, how to proceed, how to intensify. And this situation, you need a score. And the score, the ACD score, which we developed together with the colleagues in Oslo and Frankfurt, really allows to adapt during the course of the disease. So the score is different at the beginning and at the end. So and it's validated in different cohorts, not only in our department, also in Norwegian cohort and German cohorts. It's pretty valid. So you can come with good numbers if you to talk with your colleagues and of course the relatives and try to give every single patient the optimal treatment and find the balance.
Something I take from this, then, I think it's really important to, when it comes to status epilepticus, is not just to tick the box if the person leaves hospital alive with their heart beating and they're conscious, hopefully, but is to actually see what is their quality of life like. Do they go into status epilepticus again? How are their seizures afterwards? Are there any long-term impacts of the status epilepticus and things like that?
That's correct. And it's also one of the big open questions. Another study we just published was on the super-refractory status epilepticus, and what we did, we looked at the entire literature. All was published. We found more than 200 case studies published in literature, and then we analyzed every case study, which information was reported, which treatment did the patient get. We estimated the condition at discharge and kind of collected the data from entire literature in a single article. So all of the case reports, case stories. London has treated 10. India, there was a cohort of 20 patients. We collected all this, and one of the bottom line was that the treatment of the super-refractory status epilepticus is actually quite successful. So if the physicians just want to, they get all the patients they reported in the literature out of status. That was kind of impressive. More than 80%. That little bit depending what you look at. But the other part of the story is how they're discharged. And if we extract data from all these case reports, a lot of patients are in poor condition. And one of the big questions is, how do they recover? Is there a chance that will there rehab after treatment? Is there a chance to come back to life, live in your own house, or do you have to stay in a nursing home? Because this is one of the things, and related to this question is the other open thing is how dangerous is status? Is it all etiology? Is it the underlying etiology that really triggers the seizures, or is the seizure harmful? And this is another unsolved question I'm trying to work on in the next years.
Okay, unsolved question. So you'll be continuing work on that, and will your colleagues overseas also be working with you on that? Is this going to continue to be a global sort of project?
I'm contributing to the new registry, which is initiated for Nicolas Gaspard for Belgium, and he's the primus motor of a big European network where we collect status epilepticus patients, which I think is a great initiative. And this should be the way forward. If you look at hematology, lymphomas, leukemia. Great successes have been made in the last decades and years. And do you know why? Because every patient diagnosed gets into a clinical trial. Everyone who dies from lymphoma contributes to scientific knowledge. So we get one patient dies, but the future patient will benefit from this death because we learned. And this is not happening in epilepsy research, but it should be the case, especially in these very severe conditions. And from pediatric field, there are great networks working on the genetics of epilepsy, and we should have something similar in the adult neurology for those severe conditions like status epilepticus. And Nicolas Gaspar is initiated one of those networks. I'm really happy to contribute to.
Obviously, as you said, that we have this new network. What can our listeners, so other clinicians, researchers, and indeed patients, families, and carers, how can we contribute to this?
The patients can contribute by not becoming a status epilepticus patient.
Well, that is kind of like, that's kind of our focus, but yeah.
Taking the medication, prescribed medication, if you get side effects, don't just stop. Talk to your doctor. Be a pain in the neck. It's fair. You say, doctor, this is not good enough. You prescribe this medication, I'm getting sick of it. Get me something new. We have more than 20 different good substances against seizures. Your epileptologist will be able to find one. And if it doesn't, you may ask another one. This was kind of one thing for caregivers, for patients. And for physicians, I think the research community should strive to collaborate, support initiatives like this one from Nicolas Gaspar, contribute with patients, so that every patient you have in your hospital, and the patient might die or may have a good outcome, that this patient history contributes to our collective knowledge, so we get smarter and better to treat patients.
Thank you to Christoph for sharing with us just a snippet of his work into status epilepticus, but also for reassuring us that his research into how to minimise the risk for people who experience status epilepticus is continuing.